Hello and welcome back. We are now on the last of our series of lectures on the pharmacotherapy of diabetes. We're going to talk about oral antidiabetic agents and one last injectable, the GLP-1 receptor agonists. I am again Dr. Cecil Jimeno. Much like in the lecture on insulin, we will be talking about first pharmacodynamics, the mechanism of action and the adverse drug reaction, and go through pharmacokinetics or ADME, absorption, distribution, metabolism, and excretion, and then go through the principles of drug therapy. In previous lectures, we had already tackled actually this conceptual framework of the treatment of diabetes, especially focusing on type 2 diabetes, of which there are different problems, no? And therefore there are different mechanisms of actions of drugs. If you want to address the problem with the lack of insulin or the insulin secretory defect, there are two drugs that can address that, the sulfonylureas and the meglitinides. So think about it. If you want to increase insulin, you have to sum up two drugs. Sum because it's SU and meglitinides. So the sum of the two, SU and meglitinides, will lead to an increase in insulin secretion. The other major problem in type 2 diabetes is that of insulin resistance or resistance to the action of insulin, meaning you still have enough insulin, but it is unable to perform its usual action. And so to make the tissues more sensitive to its action, to make the muscles, the adipose, even the liver more sensitive to the action of insulin, we can give sensitizers. You have to meet the insulin resistance. And so for that, we have metformin, and then the T is the thiazolidine diones. So met the insulin resistance, how? By giving met. So metformin and the thiazolidine diones. The third major problem is that of the uninhibited glucagon secretion. And remember that glucagon is counter-regulatory to insulin. So you want to give drugs that not only decrease the glucagon secretion, but can also increase the insulin secretion. And these are the so-called incretin-based therapies. Incretin because incretin stands for intestinal secretion of insulin, that is during the postprandial or post-meal period. There are signals that are sent from our gut to these tissues, no, that are also found in the gut to release the incretins, and these are the GLP-1 receptor agonists. And that then would lead to an increase in insulin secretion from the beta cell, as well as a decrease in glucagon secretion. Now, the only problem with our endogenous GLP-1 or our own GLP-1 is that they're very rapidly degraded through an enzyme called the DPP4 enzyme. So what if we can inhibit the action of the DPP4 enzyme? That would mean that our own GLP-1, the one that is manufactured by our body, will stay, in the circulation much longer to perform its action of decreasing glucagon secretion and increasing insulin secretion, especially during the postprandial period. And all of these contributions, the increase in the insulin, the decrease in the glucagon, and the improvement of insulin resistance in the liver would further decrease or control the liver production of glucose, or the so-called hepatic gluconeogenesis. So that's an overview of this entire talk. So now we go to the different classes of antidiabetic agents. And I know that this is a long list, but we will briefly go through each and every one of them, beginning with the sulfonylureas. This is the sum. And then go to the met. So the bigonides is metformin and the TZDs. And then talk about the incretin-based therapies as well as two other drugs. Now, when do we use the oral antidiabetic agents? Typically, these are for any adult, with type 2 diabetes. Even children can actually take this antidiabetic agent, especially metformin. This can be the initial treatment, even if diet and exercise are untried, meaning you use these agents along with diet and exercise among persons with type 2 diabetes. But if the blood sugar levels are very high, especially if the person with diabetes is very symptomatic, we tend to use insulin, even if type 2 persons with type 2 diabetes are typically not insulin dependent. Now, if these are the indications for using the oral agents, these are, on the other hand, the contraindications. When should you not use them? You shouldn't use them among persons with type 1 diabetes because they should be on insulin. Those who are women who are pregnant, those who have allergies to these oral agents, especially the allergies to the sulfa drugs, the ones sulfonylureas are therefore contraindicated. Those with severe liver or renal impairment, because many of these oral agents are metabolized in the liver and excreted in the kidney. And diabetes resulting from destruction of the pancreas, because there's nothing to stimulate if your pancreas is no longer functional. In the presence of severe infections, insulin is preferred. And among conditions predisposing to the development of severe hypoglycemia, as much as possible, we also avoid some of these oral agents, especially the first class, the sulfonylureas. So we will begin with this first drug class, the SUs or the sulfonylureas. Their mechanism of action is very simple. They stimulate insulin secretion, and because of that action, it will also inhibit hepatic glucose production, hepatic gluconeogenesis. It's also very easy to recognize the sulfonylureas because any drug that is a secretagogue, meaning a drug that stimulates secretion of an endogenous substance, typically ends in the suffix "ide." So here you can see that whether it's a first generation SU, tolbutamide, acetohexamide, and chlorpropamide, they end in "ide." And the second generation sulfonylureas, which were manufactured because of problems in the kinetics of the first generation agents, the second gen are very easy to recognize because they are all glyide: glibenclamide, glipizide, glyclazide, and glimepiride. Now, if you will only remember two facts about the sulfonylureas, the first one is we try not to prescribe glibenclamide anymore because it's very potent. That's the number on the right, 150. It's the most potent among the sulfonylureas. And therefore, it has a great tendency to cause a lot of hypoglycemia. Why hypoglycemia? Because it stimulates insulin release. And when insulin is released, especially inappropriately, it can lead to hypoglycemia or low blood sugars. The second fact that you probably need to remember is with regards to glyclazide. This is the sulfonylurea that is actually listed in the WHO formulary as well as the Philippine National Formulary. So in the public health system, if you're going to prescribe sulfonylureas, it would be glyclazide that you will typically prescribe. And so just to describe the mechanism of action of the sulfonylureas, they act as if glucose is present. What do I mean by that? Whenever our blood sugar is high, glucose is pumped into the pancreatic beta cell through the glucose transporter 2 or GLUT2. As glucose enters through the transporters, it provides the energy it provides the energy needed for ATP generation, and this then causes a closure of your potassium ATP channel. What does that mean? If you block that ATP sensitive channel, you reduce the permeability to potassium. Potassium is no longer being pumped out. This would lead to depolarization or a change in membrane polarity. And this change in membrane polarity or depolarization causes the voltage-dependent calcium channel to open, allowing calcium to enter. And you remember that calcium is needed for movement of vesicles of insulin, which are within the beta cell. And these vesicles of insulin then fuse with the cell membrane, and so they're released into the blood circulation. So that's what happens when glucose is present. This is the mechanism by which insulin is secreted in the pancreatic beta cell. Now, in the presence of the sulfonylureas, the sulfonylureas would act as if glucose itself is present. How? The SU binds to its receptor, and when it binds to its receptor, it closes the potassium ATP channel, creating again a change in the membrane polarity. This causes depolarization, and then because of this, there is opening of the voltage-dependent calcium channel, allowing calcium to enter, allowing insulin vesicles to move to the cell membrane, releasing insulin. So I keep repeating, SUs act as if glucose is present. And this is the concept of the glucose-independent insulin release. Meaning, if you take a sulfonylurea, even if you don't eat, even if your sugar is low, for as long as the SU is bound to its receptor, which is found in the potassium ATP channel, insulin will be released. And if you haven't eaten, if your glucose is low, of course, it will cause hypoglycemia. So we need to remember that whenever SUs are given, because their action is a glucose-independent insulin release, we need to warn patients about the possibility of hypoglycemia. And so therefore, they need to eat regularly. They should not skip their meals. SUs are generally well tolerated, but as I keep telling you, hypoglycemia is a common side effect, especially when, depending on the agent you're giving, let's say glibenclamide is very potent. People with advanced age, especially because there tends to be an impairment of renal function. And if your kidney is already declining in function, this would decrease the clearance, or the output of sulfonylureas. And so they tend to stay in the circulation longer to perform that action of releasing insulin. Now, very rarely, because their SU, they have a sulfa moiety, they can cause actually bone marrow damage as well as some allergies, some skin rashes. And because insulin is released whenever you drink sulfonylureas, there will of course be weight gain, which is attributed to the insulin release. Now, like I told you already, there are first and second generation sulfonylureas. We only have the second generation now. You don't have to memorize this particular table. I'm just showing it to you to tell you that typically the sulfonylureas can be given once or twice a day, and they tend to be persisting for 12 to 24 hours. So again, I keep emphasizing, when you take the sulfonylureas, make sure that patients are instructed to eat on time, because the total duration of action of these drugs can be from 12 to 24 hours. And so after you take them, if you do not eat, then you can develop hypoglycemia. Now, the second set of drugs, the meglitinides. So again, the sum, SU and meglitinides, they both increase insulin secretion. And so the meglitinides, or the glinides for short, have a similar mechanism of action as SU. It also binds to the same receptor in your beta cell, the potassium ATP channel, But the meglitinides, as compared to the sulfonylureas, which have a total duration of action of 12 to 24 hours, they tend to be short-acting, in fact, ultra-short-acting. And this is very important because they're rapidly absorbed from the gastrointestinal tract, peak within an hour, and so this tends to avoid hypoglycemia because, as I have told you previously in the lecture on insulin, our blood sugar after we eat tends to peak within an hour. And so this action of the meglitinides ensures that insulin is secreted and it is timed well within the hour after you eat so that you avoid hypoglycemia. The tagline of the meglitinides or the glinides is no meal, no dose. So you only take them just before you eat. And these are the first prandial regulators, meaning they're the regulators of your blood sugar levels after we eat. There are two drugs that are available in the market. And again, it's very easy to remember. It's also IDE, because they're secretagogues. But because they're glinides, The name is repaglinide and nateglinide. And both of them are well metabolized in the liver. Much like sulfonylureas, they are used for patients with type 2 diabetes who do not respond to diet and exercise. Can be used in as monotherapy or in combination with other drugs like metformin or even insulin. But what do you think is the disadvantage of these drugs? Again, you have to take it before meals. Okay, so if you can imagine then, if you have to take it 3 times a day before each meal, it's a little bit difficult. And so that might be something that will work against compliance or adherence. But on the other hand, that's also its advantage. If you don't want to eat yet, fine, you don't have to take the drug. And so you minimize hypoglycemia. And so for people who where the issue of hypoglycemia is important, like the elderly, or those with kidney problems, no, the glinides or the meglitinides are advantageous. Now, because they are metabolized in the liver, used with caution among patients with liver problems, and again, because its effect will be to increase insulin secretion, its main effect is also hypoglycemia and also weight gain. But like I said, it can be used among the elderly, those with chronic kidney disease already, or even those who eat erratic meals. You don't eat the same time every day, like, for example, students, college students. And so you can just take them when you're ready to eat. And that's why they are a prandial regulator. So we're done with the first two drug classes, and these are the secretagogues. The sum, SU, plus meglitinides, would lead to an increase in insulin secretion. So now, the next two drugs, on the other hand, will not increase your insulin secretion, but will make your body more sensitive to your own insulin. And there are two drugs, like I said, metformin and thiazolidinedione. So it's not there. What's there is bigonide, because we're talking about drug classes. Metformin is the only drug under the drug class bigonides. And how then can you remember the bigonides or the bigonides as insulin sensitizers? So you can imagine that people with insulin resistance, they tend to be overweight or obese. They tend to be big. And the number one drug, no, for people with insulin resistance are the bigonides. And it's the main drug here is metformin. So metformin was actually derived from a plant, no, that had been available in Europe since the medieval times and had been used for treatment of diabetes. It's called the French lilac or Galega officinalis. There used to be two drugs, fenformin and metformin, but fenformin is no longer available. It used to be used for the treatment of diabetes and for overweight and obesity as a diet pill. But because of an excess in metabolic acidosis, it has been withdrawn from the market. So now we only have metformin, whose chemical name is dimethylbigonide. The molecular mechanism of action of metformin is not very clear, not well understood. But what we know is that it has nothing to do with insulin secretion. No? But what it does is to improve insulin sensitivity both at the peripheral tissue, the adipose and the muscle, but mainly in the liver. And because of this, it makes the liver sensitive to insulin, and therefore it will inhibit, no, or prevent the liver from making more glucose. It will improve also, like I said, the peripheral sensitivity, the muscle and the adipose to insulin, ensuring that glucose would enter the muscle and the adipose tissue for storage, and would also upregulate the glucose transporters, no? Allowing glucose to be taken up by the peripheral tissues. One other effect of the bigonides is that it causes anorexia or a loss of appetite. And when that happens, you can potentially lose a little weight, no? Up to around anywhere from 2 to, in some researches, as much as 5 kilograms. But it does not happen to everyone. This is the drug of choice for most persons with diabetes, but especially those who are overweight and obese. It also improves the free fatty acid concentration and is typically, like I said, the drug of choice for monotherapy for type 2 diabetes. So, meaning if you cannot think of a drug to give and you are sure that this is type 2 diabetes, metformin is typically the default drug. It is not only an effective drug, a very effective drug, but it is also very safe and has also been approved for children, for use of children with type 2 diabetes, and even among those with women with polycystic ovary syndrome. When they become pregnant, they're actually allowed, to continue metformin. That's how safe metformin is. It is generally a well-tolerated medication because of its mechanism of action. It does not lead to hypoglycemia, but its most severe side effect is the so-called MALA, M-A-L-A, or the metformin-associated lactic acidosis. However, it's very, very rare. No? Only 0.03 per 1,000 patient years. But if you get it, the mortality can be as high as 50%. And it typically happens among people who are already predisposed to develop lactic acidosis anyway. And these are the people with kidney problems. These are the people who have low blood pressure, low tissue perfusion, no? Such as those with heart failure, heart attacks, those with severe infections leading to sepsis, dehydration during surgery, and even respiratory failure. So any form of shock, any form of hypoperfusion, hypovolemia, or even hypoxemia, and also liver failure, kidney failure, even alcohol intoxication. They're the ones who could be predisposed to this lactic acidosis. Again, it's extremely rare. The most common side effect is gastrointestinal. As much as 5 to 20% of patients who take metformin complain of nausea, even some vomiting and anorexia, some abdominal pain, and even diarrhea. And if they develop intolerance, no, we tell them to just take a lower dose of the drug. And we try to minimize the side effects by having them take the drug after or with a meal. Around 3% complain of a metallic taste. And there will be also a known side effect is a decrease in serum vitamin B levels. And you already know that low vitamin B levels can lead to neuropathies or nerve problems. And so they are asked to take B complex as a form of supplement. So that's metformin. Metformin is a sensitizer. It is part of the drug class called the big guanides. And metformin, as well as sulfonylureas, are the most effective drugs, the most potent in terms of blood sugar lowering. But biguanides, because they are sensitizers, they do not increase the insulin secretion. Then instead of weight gain, they can actually cause weight loss. No? So biguanides are also indicated in children. It's the drug of choice for many type 2 patients with type 2 diabetes and can be used even by pregnant women, especially those who have PCOS prior to the pregnancy. So I said MET, for the resistance. And so the second drug are the TZDs, or the thiazolidinediones. So you will remember the TZDs because they all end in "-one" or zone. So troglitazone, rosiglitazone, and pioglitazone. And fortunately for you, we only have one drug now available in the market, and that's pioglitazone. If metformin acts mainly in the liver, the thiazolidinediones, the zones, act mainly in the peripheral tissue, the muscle as well as the adipose tissue, to improve the insulin sensitivity. And whoever are indicated to take metformin, typically they can also be taken. No, these are also the same persons who could be on the thiazolidinediones, except that they're not approved in children and in pregnant women. Now, primary mechanism of action of the thiazolidinedione is through the so-called PPAR gamma receptor. And the PPAR gamma receptor is a nuclear receptor. An increase in once the thiazolidinediones are bound to the PPAR gamma, this would lead to an increased expression and translocation of the glucose transport, especially GLUT4. There are also other effects, no, but all of these effects do not lead to an enhancement of insulin released by the pancreas. It will mostly be improved disposition of glucose, improve uptake of glucose in the muscle, in the adipose, and unfortunately, this drug, though, because of its action on the nuclear receptors, do not just control the glucose and fatty acid metabolism. It is also involved in water, sodium, as well as bone mineral metabolism. And that would explain some of the adverse drug reaction of this drug, which I will explain in a little while. So much like metformin, much like the sulfonylureas, this can be used by anyone with type 2 diabetes as monotherapy or in combination. And though it's not yet considered to be safe in pregnancy, lactation, and even among children. Now, I did tell you that we only have one drug available in the market. The first drug, proglitazone, was pulled out of the market because of the possibility of liver damage. The second drug, rosiglitazone, was also voluntarily pulled out by the manufacturer from the market because of apparently an excess in cardiac problems. And then remember, I told you that the receptor is the PPAR gamma, a nuclear receptor that's not only involved in glucose and free fatty acid metabolism, but also water and sodium flux, as well as bone and mineral metabolism. So remember, these are nuclear receptors, so they control the transcription of many different proteins, no, that are involved in the regulation not only of glucose and free fatty acids, but also bone and mineral metabolism and water balance. So, and it's that um, side effect or adverse drug reaction that is explained by its mechanism of action. So it causes water retention. And so it pushes those people already with heart failure, it pushes them into overt, no, or acute heart failure. And for those who are predisposed to develop osteoporosis, they do develop osteoporosis because of the, again, effect on bone mineral metabolism. And that's one of the reasons why this drug is not a lot used. No? Again, because of the weight gain, because of the water retention. Secondly, the possibility of osteoporosis and then fractures. No? And also a decline or an anemia, which is because of the increase in plasma volume. So we're done with the insulin secretagogues, the insulin sensitizers, and now we go to the next set of drugs, no? The alpha glucosidase inhibitors. So these are inhibitors of the enzyme called alpha glucosidase. And the alpha glucosidases are enzymes that break down our complex dietary carbohydrates into monosaccharides in order to be absorbed. And so if you inhibit the digestion of this complex to simple sugars, then they will not be absorbed, no, or there will be a decrease in absorption. And it's easy to recognize the alpha glucosidase inhibitors because they sound like the carbohydrates, acarbose, voglibose, and miglitol. And the way that they look like is also very similar to our glucose moieties, no? So this looks like a monosaccharide, for example. And therefore, they're able to compete, no? For the alpha glucosidase enzyme. So they bind to the alpha glucosidase enzyme instead of the enzyme actually being bound to your complex carbohydrates. However, because it does not address the underlying pathophysiology of diabetes, um, it is not very potent. It is, in a sense, similar to the migletinides because they regulate your postprandial blood sugar, but it does not. It's not really that strong, no? And if you just eat a little less than usual in terms of your carbohydrates, then you really don't need this drug, no? Because it just decreases the absorption of your sugars, no? Of your carbohydrates. And that mechanism of action also explains its adverse drug reaction. Remember that if your starches are not digested, they would go into your large intestine to be acted upon by the gas forming microorganisms that are found in our gut microbiota. And after they're acted upon, gas is produced, no? And that explains why they complain of abdominal pain, bloatedness, and flatulence, and even some diarrhea because of the undigested polysaccharides. However, it's also good because there are no reports of interference with the absorption of any other medications. So in this lecture, we talked about two drugs that are important in postprandial regulation. This class, alpha glucosidase inhibitors, and the previous rapid-acting insulin secretagogue, the meglitinides. Moving on, just to summarize the action of the drugs that we've talked about, no? We talked about the insulin secretagogues, increasing insulin secretion, the sum. We talked about improving insulin sensitivity, the MET, so metformin mainly in the liver, and the thiazolidinediones mainly in the peripheral tissues. And the last one that we just talked about, inhibition or decreasing absorption of the polysaccharides by interfering with their digestion through the alpha glucosidase inhibitors. And so all of that can be used to address hyperglycemia. And these are the drugs that we've talked about so far. So the second to the last set of drugs are called the incretin-based therapies. And just go back, therefore, to this figure of the main defects in type 2 diabetes. Again, we talked about this already, not enough insulin. But again, just to go back, the problem is not just that the beta cell does not produce enough insulin, but that the alpha cell produces an excess in glucagon. And all this then would lead to hyperglycemia. So what are the incretins? No? Because it has been known that in type 2 diabetes, there is a problem in the incretins. No? In the incretin concept, and this was a concept that was first discovered in 1964 when maybe your parents were not yet even born. They discovered that if you take in sugar, no, and you monitor the blood sugar level, if you give sugar intravenously, this is the dotted lines, versus taking the drug orally, and that's why it says intrajejunal, no, they achieve almost the same blood sugar level, blood glucose level. In fact, the intravenous glucose in this experiment achieved slightly higher plasma glucose concentration. However, it is the oral intake of glucose that actually led to a stronger or a much higher secretion of insulin. And therefore, the idea is that when we're eating, when we ingest food, and as the food is now being absorbed in the GI tract, and your blood sugar starts to go up, because of the absorption of glucose, there's now the release of gut hormones called incretins. And you've probably learned this in physiology, the GLP-1 and GIP. And this incretins, these hormones signal the pancreas so that there will be a decrease in glucagon secretion, which is glucose dependent. But more importantly, there is a release of insulin that is also glucose dependent, meaning this reaction only happens because your sugar is increasing. If your sugar is slow, there will not be a release and an action of these incretins. And so they are similar to the sulfonylureas and the glycides in that the incretins stimulate insulin secretion, but these incretins stimulate insulin secretion in a glucose-dependent manner. So once insulin increases and glucagon drops, there is now a movement or a disposition of glucose to the peripheral tissue and an inhibition of hepatic gluconeogenesis, all of which will decrease blood glucose. There are two types of incretin hormones, GLP-1 and GIP. But the more important in diabetes is actually GLP-1 because it has been known that it is actually GLP-1 that apparently decreases in type 2 diabetes. And GLP-1, as I've already illustrated, is very important because it increases insulin secretion from the beta cell and inhibits glucagon. But it is also important in terms of signaling for satiety and inhibiting glycogenesis and lipogenesis in the adipose. And so, if you're lacking GLP-1 in persons with type 2 diabetes, one strategy is just to inject it. No? So, unfortunately, because it's protein, no, it's a protein hormone, it cannot be orally ingested. It can only be injected. So GLP-1 receptor agonists or GLP-1 agonists are injectables. The other approach is to limit its metabolism and excretion so that you have more active hormones. So again, like I said, and I will show you later, GLP-1 is very rapidly degraded by the DPP-4 enzyme. So what if you can take tablets that will inhibit the action of these enzymes? If you inhibit the action of this enzyme, you will have more GLP-1 as bioavailable hormone. So the first GLP-1 analog or agonist was discovered in the saliva of the Gila monster. The Gila monster is a reptile that lives in the desert, and it only eats 4 times a year. When not eating, it's able to turn its pancreas off, stopping the release of insulin. When it's time to eat again, it secretes the hormone exendin-4. And this exendin-4, through recombinant DNA technology, has been made into a drug called exenatide. This exendin-4 is able, when the Gila monster salivates, it then secretes this exendin-4 to turn its pancreas on and stimulate insulin secretion. So this is the first GLP-1 analog taken from the exendin-4. It's called exenatide. Since then, there have been other drugs available in the market. Again, you recognize these drugs because they also end in tide, exenatide, because they're secretagogues, lixisenatide, liraglutide, and dulaglutide. Because of their effect on satiety, they can cause significant weight loss. And so it's a very popular drug in the US because of this. It causes significant weight loss. And however, because of its effects in the gut, much like metformin, it can cause some nausea and vomiting. So I already told you that GLP-1 as well as even GIP are rapidly degraded through this enzyme. And so even if we can actually make GLP-1 exact copies of our own endogenous GLP-1, it's hard to use them because the DPP-4 enzyme will just break it down very rapidly in minutes. So if we can then inhibit the action of the DPP-4 enzyme, we will have a greater amount of GLP-1 as well as GIP. And so these are then the new drugs in the market, the DPP-4 inhibitors. And again, you recognize that they're inhibitors because here you can see that the word GLP is actually in its name, gliptin, because it's an inhibitor, gliptin. So the in for inhibitor and the GLP is in the glip. So we have several in our market, sitagliptin, Vilda, Lina, Saxa, Alo, and teneligliptin. They're all oral agents. Now, They're not as popular as the GLP-1 receptor agonists because they don't cause as much weight loss, no? Because when you take them, you only increase your GLP-1 levels up to whatever it is that you have endogenously. Versus actually injecting it, you're able to increase your levels of GLP-1 through pharmacologic means, sometimes up to 5 to 7 times our own endogenous levels. And typically, those who are given these drugs are those who are overweight and obese, no? And but however, because they're a little bit expensive, no, they're typically used in combination with drugs like metformin. So we go to the last of the drugs, no? We go to the SGLT inhibitors. What does SGLT2 stand for? These are the sodium uh, L-type glucose transporters. So you inhibit the transporters for sodium that you actually find, no, in your kidney tubules. And because they're inhibitors, again, they end in but because they're involved with glucose flow, they're called glyphosines. No? So they inhibit the flow of glucose in our kidney tubules. And it's easy to remember because it's CDE, CANA, DAPA, and empagliflozin. So briefly, to review your physiology, when glucose is found in our blood, it gets filtered into our glomerulus, and then will find its way into the proximal convoluted tubule, where through the SGLT2, around 90% are absorbed. Once they go to the distal segment of the proximal convoluted tubule, the other 10% is also absorbed. Now, so that in a normal person, you will actually not have glucosuria. We don't have any glucose in our urine. So what if you can inhibit this reabsorption? So what will happen is all the glucose will now be excreted out in our tubules through our kidneys and will find its way into the urine. And if you can imagine that, that means that we not only are able to bring down our blood sugar, but you lose weight, no? Because glucose carries calories. So because the reabsorption of glucose is mediated by the SGLT2s, if we inhibit their action, we don't reabsorb glucose and it just then goes out through your tubules and then in your out to your urine. Now, because there are two main transporters, two as well as one, it is mainly the SGLT2 actually that is inhibited in terms of its action. So graphically, just to show you, it should be a reabsorb, but if you use the inhibitors, it goes out. And so this is the mechanism of action, again, of the drug. So can you imagine what will be the side effect or the adverse drug reaction of this drug? What would happen if glucose is actually exiting through our urine? Okay, so remember that glucose is a good substrate for bacteria or fungi to grow, no? And that's why you can actually develop, no, some fungal genital infections. Glucose is an is an osmole, meaning as glucose exit, it also attracts water. And so it can lead to polyuria or frequent and voluminous urination, as well as even dehydration. And that's the side effect of this drug. But the advantage is that sugar goes down, you lose weight because you're losing calories, and even potentially lowering your blood pressure because of the osmotic diuresis. So, in our series of lectures, we had talked about all of these drugs that are used for diabetes. We talked about various oral agents and two injectables, insulin, as well as the incretins, the GLP-1 receptor agonists. No? And so, again, just to emphasize, the main drugs that are used for type 2 diabetes are actually oral agents. The most potent is metformin, the biguanides, as well as the sulfonylureas. But the drug of choice for monotherapy And the base drug for combination therapy is actually metformin for many of our patients with type 2 diabetes. So I think that's the last slide. If you have any questions, you can reach me through this email address or drop me a line through Twitter. Thank you very much for your patience, your time, and your attention.